Welcome from the OT, sir.
Welcome. I gave one, just now I gave one segmental spinal for a laparotomy.
Wonderful, sir.
Good evening, Parth sir. We have some.
Good evening, everyone.
Yeah.
Good evening, Sujata.
Good evening, sir. Good evening, Amit sir.
Good evening,
Rakesh.
Dr. Sujata. Good evening. Yes, good evening.
How are you, sir?
We have some, I think, anesthesiologist from China has joined, I suppose. Yeah.
Yes, sir.
Yes, sir.
So we have shared the interest.
Today we have international.
Influence of Dr. Rakesh Prak.
Yes. मोहित सर को फोन लगाते हैं.
अच्छा सर, आप लगा रहे हैं?
हाँ, मैं लगा रहा. Rakesh, welcome, Dr. Ellen. Dr. Ellen has joined.
Hello, yes, hello. Nice
Ma'am, how are
to
you?
join you.
Yeah, thank you, Dr. Allen. Joined. Welcome to India. Welcome, Kanta ma'am.
Good evening, all.
Please bear with us for few more minutes as Dr. Said Moeed is facing some issue of login. So he will log in soon, and the moment he's login, we will start. Thank you all for joining early to this 9th Quizinar. Thank you. Welcome our international guest, Dr. Ellen. Some of guests are probably from China. Thank you for joining.
Harish Paliwal, sir, good evening.
Good evening. Good
Good
evening.
evening, sir.
we have Dr. Galen Ho. Welcome, sir. Dr. Mohit, sir, if you have joined, please unmute yourself and let us know, because then I can make you co-host so that you can share. We are also live on YouTube in case if you have any problem, or if we cross the numbers that is 100, then you can ask your friends, colleagues, students to also watch on the YouTube. I'll share the link here in the chat. Yes, Dr. Tamara. Meanwhile, Dr. Rakesh, you can share the your inputs on our guideline and the methods and the process.
Thank you so much, and welcome to another yet interesting concept of Quizinar, which is a combined initiative of All India Difficult Airway Association and the National Airway Conference, which will be in October at New Delhi. And in this context of continuing with the learning from the experts, followed by testing on the quiz, and that's why we have labeled as Quizinar, is an ongoing series of AIDAA guidelines. As you are all aware of, AIDAA guidelines were released in the revised format in November 2025, which has updated guidelines of the airway management in adults, in pediatrics, in obstetrics, for the extubation, and also some special outcome in the form of Code D, difficult airway cart, difficult airway kit, and similarly the alert form, which is an integral part of the airway management. Welcome, Dr. Mohit.
Welcome. I could somehow make it here. It's too difficult job. Anyway, just first let me take out my slides.
Perfect, sir. So today in this series, we are going to have guidelines for the purpose of extubation. We always say that flying up is important, securing the tube in the beginning is equally important, but we also need to understand that safe extubation always remains very important, because the complexity of surgeries that we are doing it, whether it be a large goiter, whether it be a tracheal surgery, whether it be an anticipated difficult airway in the beginning, whether it be a airway management around the airway and making it more difficult in the perioperative period, they all becomes very difficult. And we have the best person to take it forward is Professor Ahmed, who is presently the Vice Chancellor, and he has been the ex-chairman at the JNMC, Aligarh Muslim University. He is one of the lead author for the airway management guidelines, and presently he is president of All India Difficult Airway Association.
So I need to share my slides, right? Good afternoon, good evening to all of you. Sorry for this glitches.
Mohit, sir.
Sorry. Yeah.
Mohit, sir, I'll just introduce the other chairpersons.
Oh, yeah, sure.
So for so we have a distinguished panel of chairpersons from across the India. Dr. Air Parthasarthi, if you look at the DA, DNB, PhD, and so many. So he has more than 240 research publications with over more than 1,000 citations. He's professor at MGM Research Institute, Pondicherry. He's expert in regional anesthesia, pain and critical care, and founder of Friday educational webinar series. And you must watch his YouTube channel. I've seen some of his episodes, Pain Free Partha. It's wonderful. Welcome, Partha Sathi, sir.
Thank you.
Dr. Kanta Bhati, Senior Professor and Head Department of Anesthesiology, SP Medical College, Bikaner. She is a President of ISCT branch, Bikaner from 2020 to 25. She's organizing chairperson of Rajasthan conference, which was in Bikaner 2025, and has got special interest in trauma, critical care, regional anesthesia, and she's recipient of ISA National Diligent Award 2025. Dr. Sanjay Dheeraj sir, Professor and Head Department of Anesthesiology, SGPGI, Lucknow. He is expert in difficult airway management and perioperative ultrasound, has more than 40 national and international publications, has special focus on pain palliative care, diploma in palliative medicine, Cardiff University, UK. Welcome, sir. Dr. Sujit Khade, consultant cardiac anesthesiologist and director of Ozone Anesthesia Group, Sambhajinagar, now earlier Aurangabad, Maharashtra. He has won ISA National Diligent Award in 2022, has got special interest in regional anesthesia, international pain management. He is organizing secretary for multiple conference workshops and CME and expertise in pediatric and advanced vascular access. And since I think time of COVID, I think every week they are having one webinar on Wednesday morning. And I think there's a big number. He can later on tell us how many numbers they have done webinar every Wednesday. Welcome, Dr. Sujit.
Thank you,
Dr.
sir.
Resu Gupta, she's a senior consultant anesthesiologist at Department of Critical Care Medicine, Health City of Guwahati. She is founder member of AIDAA Guwahati City branch and very active member of All India Difficult Airway Association. Welcome, Dr. Resu. Over to sir. Over to Mohit sir.
Yeah.
You can share.
Yeah, 1 second. Let me change my now profile. Change. Right.
All the AIDAA guidelines that has been published are freely downloadable from the Indian Journal of Anesthesia. In case if you want any guidelines or if you want algorithm in the HD image, they can also be downloaded from the journal website. If you click on the journal website, click the article and click the picture, they can be downloaded in the PPT format and you can use it for your teaching, training, or even for printout to be pasted in the operating book. Over to Dr. Mohit.
Is it visible?
It's visible, sir. It's visible, audible. Both are good, sir.
Both okay, fine. So once again, good evening to all of you. Special thanks to our secretary, Dr. Amit Shah, our Vice President, Dr. Rakesh Garg. And again, there are so many panelists who has been already introduced. Thank you for attending this session. And thank you at the same time for giving me a scope to present our guidelines. I present from Al-Karim University. I'm the Vice Chancellor, and I bring my greetings to all the AIDAA members and the today's viewers as well. So, as you said, we have already been published. This article has already been, this guideline has already been published in November, way back in November 2025 in the Indian Journal of Anesthesia. And we had also published this in 2016, which has been revised in 2025. Now, I don't have any conflict of interest. And before I start, I must acknowledge that I have been, because of time constraint, I could not prepare all my slides. So some of my slides have been supported by Dr. Amit Shah, who has been helping me out to to form some of make some of the slides. So if you define extubation, it is a purposeful removal of the tracheal tube and transition from an established airway to a normal airway. That's what is defined as extubation. And if you see there are a lot of definitions as far as at-risk extubation is concerned, and it is said, we defined it as, AIDAA defined it as heightened likelihood of post-extubation complications such as reintubation, hemodynamic instability, or airway compromise. Now, what's new in this? If you see, if you try to compare it with 2016 guidelines, we have done a lot of homework, a lot of hard work has been put in, and you see there are a lot of changes which have been done, incorporate nothing new concepts in this. And so naturally, to work it out, in 2016, we did not have much of research oriented studies, research oriented presentations in our guidelines. But this time we had a steering committee, a subcommittee, experts from specialty societies. We had research questions, PICO for each guideline, and structured review of literature has been done. And we had classified for the first time this the classification of recommendations and evidences have been classified as per AHA classification. And if the evidence is absent, we did a Delphi survey to get wherever there is a gray area, we did a Delphi survey to establish a guideline which could be implemented in most of the cases, most of the studies. So if you see this, it's a gist format, what has been different from the previous guideline. We did, as I said, we have done with latest evidences. Delphi study was there, expert opinions were also there. Peri-intubation oxygen is a new concept which we have put in, which we have coined it as PEROX, and supplementation and quantitative assessment of the recovery of neuromuscular blocking drugs has been incorporated in, which are made it as one of the mandatory monitoring. And there were four-pronged strategy, which is SAFE strategy, which means safe for stratifying risk, A for assemble and assimilate and anticipate, F for facilitate extubation, and E for evaluate. We'll come to this one by one when we go into detail of it. So the other thing is we retained our three-limbed of analysis or three-limb of extubation, which we did in 2016 guideline, but certain changes have been done. We have incorporated the stage sequential extubation, which is in limb 2, and delayed extubation, which is limb 3. And then we have stuck in some pediatric extubation guideline as well, and then struck tracheal tube was also being there, and unanticipated or unexpected extubation failure was also being incorporated in this guideline. So this PEROX was new, something which was new incorporated in this guideline, and peri-extubation oxygen supplementation, which is during delivering oxygen before the extubation, during the extubation, and after the extubation has been incorporated in this guideline, which ensures that continuous oxygen has been supplied to the patient so as to maintain an oxygen saturation in the case of airway failure. So if the patient suddenly goes into airway failure, we need to reintubate the patient. We have a very good apnea, we have very good sufficient amount of oxygen reserve so that we can combat whatever hypoxic element if it exists. So the universal strategy for safe extubation, as I said, that SAFE was a mnemonic which was used in this guideline, in our guideline. S is for stratifying risk, which means assess patients' risk factors. And what are the risk factors we talk about? We said 3 Ds, which are distortion, difficulty, and disease. And 3S is secretion, swelling, and stenosis, and recognize the necessity of smooth extubation in specific situations. Now, this risk stratification means we are trying to identify whatever risk factors the patient might be having at the time of extubation, and we try to find out those and take precautions before we extubate these patients. So stratifying risk is the first thing which we do, and then we go for the assemble and anticipated, where we try to identify people who are expert in airway management, and we try to keep them at hand before we have, and if we have anticipated a difficult extubation, or the patient was already anticipated a difficult intubation and subsequently we got to extubate this patient, we also keep people at hand or persons who are expert in airway, and all those equipments which are needed for that. Means the difficult airway cart is already there at hand, and we keep it at ready hand. And we try to have a location where we can really do this extubation, where we can have all the expert gadgets along with expert opinion could be there. So location is very important, where we are trying to extubate this patient. And patient readiness means the patient has recovered from the anesthetic effect. That means the train of 4 is more than 0.9. PEROX means we are giving oxygen all through the procedure during during the before, during, and after the extubation as well. And recruitment, if the patient does not have any contraindication, then we try to recruit the lungs so that we have a good oxygen reserve, and we inflate the lungs so that the patient does not go to atelectasis. And suctioning is very important. We need to go for a good suctioning of the airway so that the secretions which are there could obstruct the airway could be avoided. So once you've done that, then we facilitate extubation. Now, facilitated again, the peroxygenation has always been there. So we maintain oxygenation, make the patient, we try to compare it with awake or versus deep, means if the patient can be kept awake and extubated, or the patient can be made deep and then extubated. So it all depends upon the patient's situation, how the patient is, what is the status of the patient at the time of extubation. And we decide accordingly, according to the surgical procedure, according to the patient's status, and according to the decision plan which we make it. So obviously, we always try to keep one thing at hand, which is the pharmacological agents. Like if you are trying to go for a supraglottic airway device, or we go for some sequential extubation as well. So we have to keep three things. We need to decide on these three things. One is what are the pharmacological and the cardiovascular response, patients avoid the intraocular pressure response, whatever response which we think that will be detrimental to these patients, we try to use the pharmacological agents so as to avoid that. We can also at times in certain situations take out the tube and put a supraglottic airway device and replace it with a supraglottic airway device, or we can go for a stage sequential extubation as well. We'll come to the detail of it one by one. So once you've done it, then we try to evaluate and and if the complications are there, then I think we need to act promptly and prevent the patient from any hypoxic events. So peroxygenation is always there. We need to always keep the oxygen patient under oxygen therapy, and that is what we need to. And once we can evaluate the patient is going to having some sort of difficulty, we need to escalate our strategy of managing these patients. So as I said, we have three-limb approach for at-risk extubation. Limb one is and before we go for this at-risk extubation, we always keep in mind that difficult airway cart has to be ready at hand. Keep it ready during extubation, and we must ensure that the recovery of the neuromuscular blocking agents have been done, and the patient's monitoring of the neuromuscular blockage is there, and we need to monitor and see that the patient has recovered thoroughly or totally from the effect of neuromuscular blockers. Now, one more important thing is if we really evidence any sort of danger or complications or any sort of events which is going to be detrimental to the patient, we always have to keep in mind the call for help. We keep the patient, and at the same time, if you see that the patient does not have any contraindication, we can go for lung treatment with 100% oxygenation. Now, if you see the recommendations of and best practice statements, the question is, there's a question which we try to analyze. One is, should the patient's lung be recruited before the patient is being extubated? And what are the evidences which we get is lung recruitment is maneuvers may be considered before extubation in adults, and the types of evidence which we have is best practice statement, and it is class 2 recommendation, and with a randomized control study which are there, and we have a level of B level of evidences. The second is, should neuromuscular blocking agents monitoring be performed during extubation? Is it mandatory for us to go for a monitoring of neuromuscular blocking agents? And what we have analyzed is recommendation is class 1. It should be done and provided, and at the same time, the TOF ratio should be more than 0.9. And it is a level A evidence. So naturally, whatever studies with whatever researches we have done on these 2 recommendations, we have seen that these are the evidences which we have received, and accordingly we have given the evidences. So limb 1, we say that limb 1 is it's a normal airway, but the clinical condition warrants us that the patient should not have any pressure response at the time of extubation. So we try to have a hemodynamic response in this patient should be minimal, so as to prevent any detrimental effect of the in the neurosurgical patients or patient intraocular surgical patients. So they need to prevent it from any cardiovascular hemodynamic responses. So clinical condition requires attenuation of the hemodynamic responses during extubation, and which can be done accordingly. And we have the awake extubation or deep extubation. Now, when we talk about awake extubation, we have the pharmacological agents which can be used to attenuate the pressure responses. And at the same time, per-operative cuff inflation with lignocaine can also be done so as to prevent the responses of the cuff on the laryngeal structures with lignocaine. And we see that the evidences, there are a lot of evidences which are there. Accordingly, and there are a lot of studies which have been done. And accordingly, we have found out the recommendations, which is randomized studies and level B recommendations, level B evidences with recommendation of 2B and 2A as far as lignocaine and extubation is concerned. So if you make the patient awake, so if you are really trying to extubate awake, extubate when the patient is awake, you need to use the pressure response to attenuate the pressure response with these drugs, which is primarily we are talking about dexmedetomidine and preservative-free lignocaine can be used, remifentanil can be used, propofol can be used, and they are all having different, there are different studies which have been using these drugs, and they have recommended it that which can be used in these situations. So, so the other thing is, if you need to go for a deep extubation, so we can, what we can do is we have a Bailey's maneuver, which we use the supraglottic airway device can be used. Now there are three techniques which can be used to remove the endotracheal tube and replace it with supraglottic airway devices. One is outrightly you take out the tube and insert a supraglottic airway device. The second is you can at the back of the posterior to the endotracheal tube, when the tube is in situ, you can insert your supraglottic airway device, and then you can remove this endotracheal tube. The other way method is you can put an you can insert an airway extension catheter through the endotracheal tube, and over that you can reload your supraglottic airway device. So there are three different techniques which can be used to avoid any hemodynamic responses and extubate these patients in the deep sedation. So the other thing is which can be done is the stage sequential extubation, and sorry, yeah. So then we have limb 2. So one limb 2 is that we have 3Ds in hand. We have 3Ds means which are difficulty because of pre-existing disease. One is delayed recovery, and the other is difficult bag mask ventilation and face mask ventilation, intubation, and reintubation. So these are the 3Ds. If the patients have these situations, before we try to extubate, we can analyze this, then probably we have to keep in mind we need to go for a stage sequential extubation. So, so what do we mean by stage sequential extubation? So as I said, first and foremost is always keep in mind that you have to keep a difficult airway cutter at hand. Neuromuscular monitoring is mandatory. See that the patient is totally recovered from all the neuromuscular blocking drugs, and monitor it with a patina for more than 0.9, and always call for help and recruit the patient's lung if need be, if you think that it is feasible and it is not going to be detrimental to the patient. So you already said 3Ds. Now, what are the options for us? So stage sequential extubation can be a possible in these situations where we think the patient we need to reintubate these patients, or the patient can have a difficult extubation because of the disease process, or because the patient can need a reintubation, or the intubation can be difficult. In this situation, it's better that we go for a supplement of oxygen through an endotracheal tube during extubation, and we need to extubate these patients with an AEC, that is airway extension catheter, or a fiber optic bronchoscope wire, so that if need be, we can reintubate these patients so that a conduit is there with us, so that in future, if you think really we need to reintubate this patient, we can railroad this endotracheal tube through this. So this is stage sequential intubation, especially when situations where the patient is conscious, the effort is there, but he's probably not being able to survive after extubation, not being able to sustain his normal extubation even after extubation, and there we need to reintubate this patient. So this is a situation where we need to always keep some conduit in the endotracheal, in the larynx, in the trachea, so that we can immediately reintubate through it. And if you see the recommendations that in adult patients at risk extubation failure, if you think that patient can be having it, so does the use of AEC facilitate extubation, reintubation? So the use of AEC can be beneficial to facilitate a reintubation in adult patients at risk or extubation failure. And the best practice, this is also a best practice statement, and it is recommendation is 2A with a non-randomized controlled study, and level of evidence is B. Stop.
Sir, you
The other thing is you
want
have
me
to
to
very
share?
conscious. The other point is we need to keep, I'm going on. The other point is we need to keep in mind that whenever we're putting an AAC, we should never we should supplement oxygen through it, because then it will be very detrimental to the patient's lung, and then the patient can be endangered. So it's always advisable not to put oxygen through the AAC. See, there's getting stuck. Let me share it. Okay. So once we have extubated this patient, or once we have put an AEC and extubated this patient, then you always need to see that we need to maintain the oxygen. So what we can do is we can do it through a CPAP maneuver, or an NIV can be started, or HFO can be given, because oxygen supplementation is very important in this situation. And as we said, after into extubation also, oxygen must be there. Otherwise, the patient can have, anytime the patient can be in hypoxic state, and so we have to take care of these patients. So oxygenation is the mandatory, or parox, as we said, is a defined condition which we always keep in mind, and we always give it. The third limb is the limb 3, which we again have 3 S's there. One is the suspected airway collapse in patients where we suspect that the patient can have an airway collapse right after extubation, or where the patient has suspected that an airway edema is there, existing in the patient's edema because of prolonged surgery or prolonged anesthetic procedures, and if the patient has a surgical cause of airway compromise. Say, for instance, the patient had an airway tracheal operations or laryngeal operation done. So where we always expect some sort of airway compromise is there. So in those situations where we think that the patient has an edema, airway edema, we always try to go for a leak test. And naturally, if we have a leak test absent or equivocal, always we consider steroids in these patients. So we'll come to that leak test one by one. So again, before extubating these patients, we always keep in mind the airway cart should be there, and the tracheal airway cart should be there, and the patient should be having a neuromuscular blocking agent should always be there. The monitoring should be there, and call for help should always be there. The other thing is, now these patients needs to be, go for a delayed extubation, and which can be done either in HTU or in intensive care unit. And post-operative ventilation should be done. Patient breathing spontaneously on T-tube, TPS trial can be given into this patient, and patient can be extubated after in a delayed situation, delayed extubation. That means the patient can be kept on tube for a period of say 24 hours, and the patient's edema could be subsided with adrenaline or steroids, and subsequently the patient can be extubated once the patient is been made ready. So what we mean by leak test is the patient has, and we try to inflate the patient's lung with a fixed tidal volume of 8 ml per kilo body weight, and we see the expired tidal volume. And when we deflate the patient's lung in patient's endotracheal tube, and we see a cough, in fact, and then we see the amount of air which is coming out. So if the difference between the inflated and the deflated cuff is more than 110 or 1 to 130, or more than 10 to 15%, then we say that probably the leak test is negative, and the patient can be extubated. That means the patient has a good amount of leaks where the patient can sustain extubation in these patients. At the same time, nowadays we go for an ultrasonographic test, where we try to put the probe at the level of this vocal cord, where we see the airway column width difference And where if it is more than 9 millimeter, then probably the patient can sustain the extubation as well. The patient might not have any edema, or they might have a collapse as well. So if airway edema is suspected, always keep in mind we need to go for epinephrine embolization, or dexamethasone IV steroid can be given, and that can prevent. So we need to give it, see that how long. If there is edema, we can keep it for another 24 hours on the tube and then ventilate the patient. Once the edema subsides, we can extubate this patient. So that is what we talk about delayed extubation. And when we say that what are the recommendations which we have? Okay, so what are the, does performing or the cuff leak test prior to extubation reduce the chances of extubation failure when airway edema is suspected? Quantitative cuff leak test may be considered before extubation when airway edema is suspected, and best practice statement is this. And we have class 2 recommendation with limited data and level C evidence. So this is what we are talking about, cuff leak test or airway column width differences. So we usually go with, I've already described this, that the difference, if it is more than 110 to 130, then obviously we say that the post-extubation stridor should be anticipated. If it is less than that, then the post-extubation stridor should be anticipated. And in this situation, we have to take precautions not to extubate these patients. We can go for a delayed extubation. Alternatively, we can go for the cuff inflated and later after cuff deflation, and we find out the airway column with differences. If it is more than less than 9, obviously we always think that these patients can land up to stridor, and where the patients should be gone for delayed extubation. And as I said, cuff leak test is negative or airway column width is more than 0.9. Obviously, we can go for extubating these patients. And always keep in mind, post-extubation, always have to keep NIV and HFNO because of peroxygenation, which will prevent them from hypoxic problems. So the other thing is suspected airway collapse. Airway collapse, also known as tracheomalacia, occurs when the walls of the trachea and bronchi are weak and collapse during breathing, leading to compromised airway defalling instrument. One very important thing which we always should keep in mind, because there is a wrong concept. The primary leak test should always be done in patients who are having edema, airway edema. Cuff leak test does not hold good in patients where we have airway collapse. That does not, the cuff leak test does not have a very good role in those where there is airway collapse. So even anything which we have airway edema, it's better to go.
Oh, well. Dr. Mohit sir seems to facing some internet issue. Let's see if he can join. We'll just
Sir, he
wait.
has joined,
Try to.
but he is.
I also have some of slides. If he wants, I can share and he can talk. Okay.
Actually, here we have a lot of thunderstorms and a lot of rains.
Sir, if you just, sir, if you want, I can also share some of the slides.
Just see,
and then you can just try if you can again. I'll need to make you if you're gone.
Did I join? Did I join? Can you see me? Can you see me now?
Yeah, no, sir, we are not able to see you right now.
Okay. So I need to
let me find out.
Amit sir, we can see.
No, sir, we are able to hear you. We can hear you.
But you cannot see me.
Amit
yes,
sir, we can.
Sir.
Can you see me now?
See.
Yeah, you are able to see me, right?
Yeah.
So I think I need to.
Yeah, we are able to see you.
So I need to slay my slide.
Yeah, just hold on, sir. I need to find out and make you co-host again.
Actually, we are having a lot of, the weather is very bad here. So we are having a lot of airway connectivity. I mean, internet connectivity is not. not very strong here now as of now.
Sir, you can share your post. You can share, sir.
Yeah, now I can share. Yeah.
Just try to share.
Yeah,
Yeah, you can share.
I'm sharing.
Meanwhile, Professor Mohit back, we have shared one link. So when you click this link, just fill your information. We'll be issuing one certificate and also on email that you will enter on this Google form.
Can you
Will be-
see my slides now? Can you see my slides?
Yes, sir.
Yeah. So naturally, if we are failing, that means the patient's airway obstruction still persists and the intubation has then obviously we need to, if we think that the patient reintubation is required and time and again we need to reintubate these patients, then probably we have to go for a planned tracheostomy. Or at times we can upfront go for a tracheostomy if we think that the patient's really situation is not good. So is the airway compromised because of some surgical techniques which have been done, surgical procedures which have been done. So in that situation, naturally, one second. Yeah. So naturally, surgical cause of airway compromise, the patient has undergone some sort of surgical operations where it's extensive procedures or prolonged procedures where probably patient has the airway is compromised. In those situations, we again need to go for a delayed extubation. Or if we think that the patient's airway will be compromised even after repeated attempts of extubation, it is better that upfront we can go for a tracheostomy as well. And in places where we don't have those facilities which are needed, say for instance, putting the patient in an intensive care unit or an HTU, or we don't have those gadgets which can we can use to prevent this patient from and make the patient on a delayed extubation, then probably can go for an upfront tracheostomy as well. Otherwise, it is advisable that we go for a delayed extubation in these situations with the same technique of putting the patient on AEC or a fiber optic bronchoscope. Good stuff. Yeah. So pediatric extubation, a few words on this. We have the SAFE strategy. That means stratifying risk. And again, we have 3Ds, distortion, difficulty, and disease. 3 S's, which is secretion, swelling, and stenosis. This is predominantly very important in pediatric patients because the pediatric patient's airway is already narrowed, and if you have a lot of secretion and swelling, stenosis, then probably the patient will be in a compromised state. So we need to recognize them and go for a smooth extubation in this situation. The other thing is, again, the at risk for try to assemble and anticipate in this situation. And so naturally, we have to keep the specialized patient who are the persons who are doing pediatric anesthesia, pediatric management, pediatric airway should always be there, who are much more better in these situations. Equipments, carts, the difficult delivery cart should be there. Location where need to go for, always better to go for in operation theater to extubate these patients. And patient's readiness means the patient has to be away from all the neuromuscular effect, blocking effect, and peroxygenation should always be there. Recruitment of lung, if the patient is feasible to go for recruitment, and if you're not contraindicated, and if you need to go, and suctioning of the patient's airway is again how to make the patient ready. Then obviously facilitate extubation, peroxygenation always there, airway, awake versus tube has to be kept in mind whether they need to go for an awake or a deep extubation, and pharmacological agents, supraglottic airway devices, or state sequential extubation has to be planned accordingly. So post-extubation oxygenation is again stay alert for any potential complications and readiness to deal with it. And pediatric, as you know, that pediatric reserve is very less. It does not give you much time. So it is more so important that we have to be much more vigilant in these patients when we extubate these patients. So unanticipated failure, especially emphasis should be given on oxygenation. We always keep in mind that any patients where we already stratified risk, where we anticipate the patient has been difficult to extubate, we always are prepared. But in situations where the patient is unanticipated, you never expected this patient to have a difficulty or to extubate, or the patient will land up to an extubation failure. It becomes much more important for us that the oxygenation is very important, or peroxygenation is more important in these situations, and always try to achieve rapid and reliable oxygenation. Face mask or supraglottic airway device is preferable, or HFNO could always be advisable, and reintubation is a better option in this situation. If you really, these are the evidences which we must always keep in mind, thus performing what we are talking with all the recommendations which we have already discussed in short for. Thus, performing the leak test prior to extubation reduce chances of extubation failure when airway edema is suspected. Obviously, as we said, best practice statement and class 2 evidences recommendation with and then should neuromuscular blocking agents should be monitored. Obviously, we said recommendation class 1A, class 1, and evidence level of evidence is obviously A evidence. And so there are three things: does tracheal tube cuff inflation with lignocaine in adult patients, hemodynamic response can be avoided, or does tracheal cuff inflation with lignocaine in adults reduce cough or laryngeal symptoms, and does tracheal cuff inflation with lignocaine attenuate the hemodynamic responses? They are all best practice treatments, and we have level class 2 recommendation, class 2A recommendation, and class 2A recommendation in all these situations. Finally, should extubation be performed awake or deeper in planes of anesthesia in pediatric patients? And it is not well established whether extubation should be performed awake or deeper planes of anesthesia in pediatric patients. So it is a best practice statement which is given as class 2 evidences. And should lung recruitment maneuver be performed in before extubation in adult patients? Again, lung recruitment maneuvers may be considered before extubation in adult patients. Best practice statement, and it is class 2B evidences. And failure in adult patients at risk of extubation failure, does the use of AC facilitate intubation? Obviously, it is best practice statement, and it is class 2. So to summarize, extubation is a planned procedure, and please mute yourself. Okay. So safe that means stratify risk, assemble and anticipate, facilitate extubation, and evaluate and escalate should be the strategy whenever you have. Since we know it's a planned procedure, we should always plan accordingly, and this mnemonic holds good in most of the extubation procedures. So use neuromuscular blocking monitoring before you extubate this patient. See that the patient is totally recovered from neuromuscular blocking agents. Peroxygenation is very important. Before oxygenation, during extubation, during and after extubation, oxygen is a must, and we should always keep this mind so as to have time with us if the patient goes to any detrimental situation. So not all patients can be extubated in single step approach. So always use a conduit, especially in situations where we anticipate that the patient can have a difficult to reintubate this patient, and we have seen that 3D and 3S. There are situations where AEC or stage sequential extubation would be a better choice. Putting an AEC as a conduit through which we can reintubate this patient as and when needed. So supraglottic airway exchange is again a good option, especially in situations when we don't want any hemodynamic pressure response, and we need to make the patient's stability as far as neurosurgical surgical operations are concerned or intraocular operations concerned. We can replace the tube through OMBI and supraglottic airway device, so which can be tolerated much more better. We can also use some anesthetic, some local anesthetic agents like lignocaine, which we've used. Delayed extubation is a situation for compromised airway. Leak test may be helpful in situations, especially in airway edema, not in airway collapse or airway compromised situations. So elective tracheostomy could be an option, especially in situations where we think that the patient needs to be reintubated time and again, or patient cannot be extubated on its own. So in those situations, it's better that you straight away go for an upfront elective extubation, tracheostomy. Thank you so much.
Thank you so much, sir. Thank you for the answer. I will request.
Here, please.
Yeah.
Thank you so much. So thank you, Dr. Mohit, for elaborate AIDAA guidelines on the extubation. So I'll hand over to the chairperson today. Dr. Partha Sathi is with us, Dr. Kanta Bhati ma'am, Dr. Reshu Gupta, Sujit Kumar Khade, Dr. Dhiraj is with us. So open to you. You have comments, your experiences with regards to the extubation management and how they sync with the guidelines. Over to you, sir.
Yeah, sure.
Full presentation, sir. Very nice presentation. And you have managed the whole thing within the short time, sir. Good. And I just want to tell, taking out the tube is not extubation, and it is about maintaining airway patency and ventilation for the next 30 to 40 minutes. That is what is matters in good extubation. I have one more thing to tell. During intubation, if in doubt, take it out. During extubation, if in doubt, keep it in. That is what my routine thing, sir. Over to next chairperson.
Yeah, that's very good. A good.
Dr. Sujit.
Yeah.
Yes, Dr. Sujit. You
Dr.
need
Sujit?
to unmute yourself.
I'm audible.
Okay.
Yeah,
Yeah,
now
yeah.
audible.
Audible.
Thank you. Thank you, Amit Shah sir and Rakesh Gar sir for this wonderful initiative. The Quizinar format is really innovative and I am really honored to be part of this as a chairperson. Dr. Syed Ahmed, as one of the co-authors of this landmark AIDAA 2025 extubation guidelines published in IJ, you have given us a master class and your clarity on the safe and this three-limb approach has made this complex topic very accessible. So thank you for your wonderful presentation. I have a few practical points to share with you. The guideline rightly emphasizes quantitative neuromuscular monitoring with 10 of 4 ratio of more than 0.9 before extubation. And the role of Sugama Dex as a reversal agent at risk airways is well established. So here is a small but important practical trick which I use in my clinical practice. I dilute 200 milligram of Sugama Dex, that is 2 ml, into 10 ml syringe and give it as a slow titrated dose while watching the patient. So why to dilute and give slowly? Because if you push the Sugama Dex rapidly, the patient immediately starts fighting with the tube in situ. And that many times forces you to a hurried extubation. And you may then find that the patient is apneic because full diaphragmatic recovery was not there. So by giving it slowly and titrating it over few minutes, you allow the diaphragm to recover first. Then patient begins to breathe comfortably and does not fight with the tube. So then you have ample time to observe the patient's breathing quality. Then you can extubate the patient in a controlled manner and give the remaining dose once patient is extubated. So this is a very small trick, but it has made difficult extubations. Many times there are obese muscular patients. In those patients, it is really useful and it has helped me. Now, the second point, which already Dr. Said has covered, that is stage sequential extubation. And as per the AIDAA guidelines, the airway exchange catheter, that is AEC, is preferred conduit for the SAC. So I want to add one clarification specifically for the residents who are watching this webinar, because there is many times confusion between the AEC and the bougie. So AEC and bougie, they are not interchangeable. AEC is a hollow, it has a marking, it is a long length, it is almost 83 centimeter length, and it is designed for tube exchange. While the gum elastic bougie is shorter, solid, and semi-rigid. So it is introducer for difficult intubation. So we have to remember this. And the third thing about this bougie is that many times we use this term called as the ventilating bougie. I think it is a misnomer, because though we can connect the oxygen to the proximal end of this ventilating bougie, it is hollow. But as the AIDAA guidelines clearly state that oxygen supplementation or the ventilation should be avoided through AEC or this ventilating bougie, because this jet ventilation through these narrow catheters can cause serious complications like barotrauma, then pneumothorax, and many times cardiovascular collapse. So I advise not to use this so-called ventilating bougie for giving oxygen post extubation, particularly in difficult airways. And my last point is the bedside reflex that every anesthesiologist should try to build. The guideline under evaluate and escalate rightly lists the negative pressure pulmonary edema as the post extubation complication to watch for. When your patient is biting on the endotracheal tube and attempting to inspire against the obstructed airway. That is the first thing you have to do is the deflate the cuff. This immediately relieves the negative pressure being generated against the closed glottis, and this can prevent the development of negative pressure pulmonary edema. So I think this is very simple reflex, but you have to develop it. That is deflate first and manage next. And this can prevent the dangerous complication of negative pressure pulmonary edema. So in summary, give Sugammadex slowly with intention. Note the difference between AEC and the bougie. Then don't use the devices like this ventilating bougie for per se ventilation, and always deflate the cup before patient is biting triggers the pulmonary edema. So these are very small things, but what I found in my practice that these small things are very useful to prevent the post-extubation complications. So I once again thank Amit Shah sir and Rakesh Garg sir for giving me this opportunity. Thank you, sir.
Just a query. I mean, whatever you said is absolutely appreciable and acceptable. One point I just want to say that do you mean, and when you're giving Sugammadex, do you mean to say that we don't need to monitor the with the help of neuromuscular blocking drugs?
No, definitely, sir. We will monitor,
So
monitor, but instead of giving, if the TOF is more than
whether you give Sugammadex or you give neostigmine or whatever it is, glycopyrrolate combination, whatever you give, but monitoring is the recommendation which we always given. We have given in this guideline that even before before you extubate this patient, you should need to monitor this patient that the neuromuscular blocking effect has gone, means it is more than 0.9. And then whether you use Sugammadex, also you have to go for a monitoring done. So
yes, definitely, sir.
So
but instead of giving the bolus, give slowly in a titrated manner.
Yeah, so most of the institutions, of course, people are now converting, I mean, reversing back to Sugammadex. I mean, they're coming back to Sugammadex, but some institutions where they cannot afford, they are still going on neostigmine and atropine or neostigmine glycopyrrolate combination. And there also, obviously, we have to keep this in mind that we need to monitor the neuromuscular blocking effect of the drugs. So that is must.
Yes.
The other thing is what you said is the bougie and the AC, airway extension catheter. Naturally, I have also mentioned in my slides that we should not give oxygen through this bougie, I mean, through this airway extension catheter, very important thing. And bougies are primarily to intubate a patient. Whenever you are not being able to identify the epiglottis or identify the glottis, obviously you go for a laryngoscope and go for pass a bougie, and through that you railroad your tube. Or you keep the bougie there and you can railroad your tube as well. So this is totally different. And when you go for an extubation, you always keep an airway extension catheter, so that which is obviously, as I said, you said that it's a hollow structure, which is hollow equipment, which is being kept at the time of extubation. So there's a clean-cut distinction which is there, which I've already mentioned there, that airway extension catheter and bougie are two different things that that should be kept in mind. And third, you said is what was the third point you said?
Sir, regarding this, immediately deflate the cuffs to avoid the negative pressure pulmonary edema.
This is the point which we are trying to emphasize, that if the patient is really, we should not allow the patient fight on the tube. The most important thing is we should not allow the patient fight on the tube. And to avoid this fight, we have either in the form of awake extubation, where we are trying to put the patient with a supraglottic airway device at times, or a deep extubation where we are trying to make the patient deep under dexamethasone or remifentanil, whatever it is. So fighting on the tube itself is a detrimental situation in any situation, whether the patient has a neurosurgical surgery or an intraocular surgery or any other surgery as well. So to avoid pressure response and all complications, fighting on the tube is never accepted and never being allowed in any situations. So that is again my point, and we need to take precautions to avoid those situations wherever we think that the patient can fight on the tube. So we should never allow the patient to come to that level.
Yes, sir.
Yeah,
thank you, sir. I think Dr. Dheeraj sir and Dr. Kanta ma'am. Yes, sir.
Yes.
Kanta ma'am, yes.
Yes. Yes, sir. Thank you, Said sir, and thank you, Amit sir and Rakesh sir, for conducting the webinar at risk extubation, because most of especially the resident, for that the intubation is difficult and the extubation is as easygoing, and they'll end up the patients in complication, especially those patients with prolonged surgery with the laparoscopic surgery, where the CO2 is sometimes is not let out, and surgeon with their busy list. So they shifted the patient earlier, and sometimes the patient had undergoes the hypoxia and shifted to again to the OT for intubation. That's the this webinar that emphasizes on the extubation, how to extubate and what are the guidelines is more important for understanding of the PG student. So thank you, sir, for conducting this webinar.
So
And
I just-
to my experience, the post extubation oxygenation is must. So every patient should be given 5 to 10 minutes after the extubation. So most of the complication is self down. Thank you, sir.
So my point,
Dr.
one
Dheeraj,
important
sir?
point is, just to Dr. Kanta, I just want to emphasize here to the audience as well, that see, whatever gadgets, since we are talking about the difficult airway, whatever gadgets has been established, they're primarily for intubation. Every year we come up with some new gadgets for intubation, and more emphasis has been given on intubation. And subsequently, we saw that we were overlooking our extubation procedures and techniques and guidelines. So naturally now we can see that extubation has led to more than 13 to 18% mortality in situations where we really are not being able to manage. So since we have less gadgets for extubation, so we have to be more vigilant.
Vigilant, yes, sir. More vigilance is
During extubation, because intubation we are assessing the patient and we are trying to have all the gadgets are there. Nowadays, every gadgets are there to intubate a patient every year. So naturally, extubation we don't have much gadgets. So either we have an airway extending catheter, or we have high flow nasal oxygenation or NIV to prevent hypoxia. Only airway extending catheter is the one of the most important gadgets which we have. So naturally, we have to analyze and assess before you extubate this patient so that we don't land up to any critical situation. Yeah.
Yes, sir.
That's it.
Yes.
Thank you.
Thank you.
Any
Sanjay,
other?
sir?
Yeah, Sanjay.
Yeah, no, sir. We will first take comments and
okay.
suggestions from chairperson, and then we have lot of queries which are there in our chat box. We'll take one by one. Dheeraj, sir.
He join किया कि नहीं किया?
Sir, you have to unmute yourself, sir. Dheeraj, sir.
Sorry. First, I would like to congratulate
Meanwhile,
Amit sir and Rakesh sir that they have roped in Mohit, and as you know, he's a great teacher and he loves to teach, and he has covered the topic very well. And the only point I would like to stress is that when we have large goiters and which are long standing, then mostly what we see is that these patients have tracheomalacia, and what happens is that that can be like the surgeon knows that the tracheomalacia is there, they can communicate, and we also get a what we say leverage in extubating this patient because the thyroid has been removed, and so the intubation now the intubation becomes easier even if we have that small gap in extubation, that small flaw in extubation. But the difficulty what I face and would like to ask Mohit also is that when these patients who have large goiters, they also have recurrent laryngeal injury, and these patients are some subsets of patients which I now also am not able to manage beforehand. That if I take out the tube, then will my airway be maintained or not? And should I, if the surgeon says that they have injured or they suspect that their injury of a recurrent laryngeal nerve is there, should we always extubate these patients on a exchange catheter, or there is a safer way to do it?
See, most importantly, if the patient is having collapsed tracheomalacia, so it is better that you keep the patient on tube at least for 24 to 48 hours.
Yeah.
Let the patient recover, whatever recovery the patient can have. If now you got to analyze whether the patient has a nerve palsy, I mean focal cord palsy, recurrent nerve trauma, or it is just the tracheomalacia only. So whatever it is, you need to analyze this, and there are a lot of, devices, even the endotracheal tubes are there, which can analyze that whether the patient has a laryngeal nerve palsy or not. So you got to analyze that. Yeah, yeah. So most importantly, we need to analyze and then keep the patient on tube for some time. And if you think even then the patient is not being able to come up, we can even then extubate with under an AEC or fiber optic. Try to see whether the patient is really getting collapse or not. And if even then the patient is not being sustained, we have to go for a upfront tracheostomy. That's the only thing.
Thank you.
Dheeraj sir. So, Dheeraj sir. So, another addition to what Mohit sir already said, that is why there is a provision of extubating over a flexible bronchoscope. Okay. So these are the specific situations where we can use flexible bronchoscope to extubate. So in such a situations, in flexible bronchoscopy, the reason for waiting for 24 to 48 hours is that sometimes there is a soft fibrosis which can develop, which can reduce your tracheomalacia. So you can wait for that time frame where soft fibrosis can happen and can reduce your tracheomalacia. Then you extubate over flexible bronchoscope and find out whether gradually you withdraw the tube and gradually withdraw your bronchoscope from the area where you are suspecting tracheomalacia can occur. And if tracheomalacia is still there, that means if there is a still collapse, you put your tube back, and then of course you decide to do whatever later on, whether you want to do tracheostomy or whether you want to wait. So extubating over flexible bronchoscope will help you to identify both the problems, including recurrent laryngeal nerve palsy also, and then you can always re-intubate if needed. But once you have ruled out the recurrent laryngeal nerve palsy, you can always extubate over airway exchange catheter also. And then, once you extubate over airway exchange catheter, you can identify, and then if later on, if needed, you can always do re-intubate and do tracheostomy. So flexible bronchoscopic guided extubation is specific to this particular situation of tracheomalacia. Yes, Dr. Reshu Gupta.
I think
Good evening, sir. I
before
think
we move to
beautiful.
Dr. Reshu,
Yes, sir.
we can ask Dr. Sujata ji to comment.
Okay, no problem.
Dr. Sujata, please.
Hello, am I audible, sir?
Yeah, audible.
Yeah, good evening, everyone. This was an excellent presentation. Three things I want to know from sir. We were talking about tracheomalacia, or as sir has rightly said, about one of the S, that is suspected airway collapse during extubation. So in our AIDAA recent 2025 guidelines, we encourage giving muscle relaxant for intubation if there is an airway collapse. So do you really advise to give further dose of muscle relaxant for extubation if there is an airway collapse, or would you deepen the plane of anesthesia?
Sorry,
ma'am, what you are so what you are suggesting is that when you extubate, okay, now if you go through limb 3 in the later part, there is a deepening of anesthesia, that is patient is breathing spontaneously. You take patient back to operation room, okay? After 20, first you try and see that they still collapse. So you don't need to give relaxant. The patient is breathing spontaneously. You give anesthesia. The reason of extubating under in operation theater under anesthesia is that the patient's struggle is less, and then the soft fibrosis which might have developed can actually go down. So you take patient to inhalation into operation room with the endotracheal tube in. You again give sevoflurane or whatever inhalation anesthetic you decide, and then you gradually withdraw your tube under anesthesia, patient spontaneously breathing over airway exchange catheter or flexible bronchoscope, and find out is there any further collapse. If the collapse is still there, even under sedation where patient is breathing spontaneously, then I need to put you back and then do tracheostomy. Or if patient is you feel that yes, tracheomalacia is not happening, then you still put airway exchange catheter and then extubate the patient. Yes, sir. Mohit, sir, am I right?
Yeah, exactly. My point is we never think of giving a muscle relaxants to these patients once you have reversed the patient. So my point is because most importantly, whenever you think that is what is most, when we talk about safe, you're trying to stratify risk. You're trying to assemble and evaluate the patient and facilitate and evaluate the patient when you're talking about escalate as when we're talking about extubating this patient. So that safe strategy is there. Before you extubate this patient, you always need to see that whether the patient will need reintubation. And most importantly, when you talk about the surgical aspects, we know that these are the surgeries where the patient will have a collapse. And in a situation where the patient has a collapse, we'll never extubate outrightly. We'll always keep either a bronchoscope or a AEC. And so that is there as long as AEC and bronchoscope is there. So the question of relaxing the patient does not arise at all. So we are not going to relax the patient.
Okay.
You'll always
That's very true about certain surgeries, sir. But if you are doing an obese patient, or say 130, 140 kg patient who is having a double chin, who is having a very higher neck circumference, and even though taking all the precautions of extubation, the airway, there is a sudden collapse of the airway. So in that scenario, what is your take?
One clarification we should do even for intubation, that the neuromuscular blocking is not for the collapsed airway. So when we say the use of optimal neuromuscular blocking is because there are various structures which are involved during the airway management. Patient neuromuscular blocking is not effective, the airway becomes difficult. So it is not primarily for correcting the collapsed airway, because this is not going to help. For example, if we see the parapharyngeal and paralaryngeal muscles and the tone, if they are higher, the laryngoscopy becomes a little difficult, lifting becomes difficult. So that's the purpose of giving them an optimal neuromuscular blocking agents. So we should not be a little confusing for the airway collapse versus neuromuscular blocking versus the musculature that becomes tight when the neuromuscular blocking agent goes up. So that's the primary difference. And that is what the AIDAA guidelines are very clear, that if you have a collapsed airway, it has to be opened up. So there is no confusion about it, whether intubation or extubation through whatever measures. Dr. Shah.
And what we have suggested so far is for infraglottic collapse. There's a different thing. What you're suggesting in obesity or OSA patient is supraglottic collapse. What we are very clearly identifying is an infraglottic collapse, where we are discussing about tracheomalacia. That would be, you need to keep airway open. That would be a different situation. But what we are discussing is an infraglottic airway collapse.
Okay, got it, sir. One more question, if you allow me. Can you just elaborate a little bit on airway column width, which is on which we detect on ultrasound? As you said, it is one of the important parameter to for extubation.
So this is a situation. This is a way of assessing whether the patient will go to a post-extubation stridor. Initially, we always used to analyze with the help of cuff-link test. Now, what we are doing now recently, since we are using a lot of USG guided techniques, so we put the probe at the level of vocal cord, and the patient has an inflated cuff endotracheal tube, right? And then we see the column width of column, which is there between an inflated column, inflated endotracheal tube, and a deflated endotracheal tube. So when that inflated endotracheal tube airway column is seen and deflated is seen, if the difference between this is more than 9 millimeter, then obviously we say that the patient has a sufficient amount of passage of airway and the stridor would be less. So this is the chances of stridor will be less. So this is what we are trying to do. And this is also done in most of the situations as well. Yes. Amit, you would like to add to
Dr.
this?
Reshu, please.
Yeah,
sir. Basically, if you go through literature, we have also mentioned inside, and there's a changes in the shape, and you can measure the air column width is very clearly and easily identified. It is very well described even in literature also. There you can see and you can identify it very easily. So that is one of important consideration apart from the quantitative test, which we have already suggested even in 2016 guideline. So now we have ultrasound, which is very frequently used by all of us. So that also can be added. Dr. Resu, ma'am. Yeah.
Yes, sir. Good evening, sir. Very well presented, sir, topic. We have learned a lot. So I'll just highlight few points regarding intensive care scenario, because I'm being an intensivist here. Regarding the cuff leak test, now in patients in ICU, at least in my unit, what we are regularly doing and practicing is, because the patients are on endotracheal tube, maybe for a prolonged period, patient has been ventilated for its own reasons. So we do follow a cuff leak test, followed by what Mohit sir have rightly said, the use of ultrasound. So use of ultrasound have come very much into action, and we use it regularly just to see whether the patient have any tracheal collapse or whether the chances of that extubation failure is there. Second is post-extubation, the use of high-flow nasal cannula. Again, recommendations and guidelines, they are coming up in a very big way, that use of high-flow nasal cannula post-extubation, especially in cases if the patient was intubated because of ARDS or any hypoxic related condition. So there the high-flow cannula, and even in post-op patients, we say prolonged OT, and then patient was intubated electively for maybe 24 hours or 48 hours, whatever is the reason, then high-flow nasal cannula works good, and even evidence have proven it and have supported it. Third point I just would like to mention is regarding the when we are doing a weaning, and in delayed weaning, we use regular use of T-piece versus the pressure support ventilation. So what I think Mohit sir had mentioned, I think Sujit sir had mentioned regarding the negative pressure pulmonary edema. So now even in the weaning criteria, they have said the use of low pressure support ventilation as compared to the T-piece trial, what they have given, because T-piece, they lead to more of negative pressure pulmonary edema. So they have said patient kept on the minimum pressure support and extubated thereafter, then put on either high flow nasal cannula or NIV as per the patient recommendation. That is just few points from my end. I may look forward to some comments from my teachers and seniors, sir. Mohit sir, or Amit sir, or Rakesh sir, anyone.
Yes, Reshu, I think, I mean, actually, if you talk about extubation in an intensive care unit and extubation in an operation theater, they're two different, aspects. Because when you talk about extubation in intensive care, you need to always keep in mind that the patient is being extubated not before 3 days or 7 days, or in fact, more than that. And in those situations, extubation is also considered depending on the patient's lung, what the patient's lung says. So, and at the same time, when the patient is there on tube for a period of more than 7 days, there are a lot of changes which takes place in the patient's trachea. So we will not be able to exactly compare, because we have guidelines for extubation in critical patients, which is a totally different, because not only the cuff leak test which identifies it, is because of the consciousness of the patient, the GCS of the patient's cuff leak test is one of the important, and that at the same time, the patient's, apnea, the airway pressure, which is again a component which is being analyzed to extubate these patients. So what is the airway pressure? What is the cuff leak test? What is the patient's lung status? What is the patient's GCS? So it's not only one criteria on the basis of which you can extubate a patient in an intensive care unit, right?
True.
So cuff leak test, the importance of cuff leak test on single parameter, I think will not be a very good idea to extubate any patient in intensive care. One very important thing. The other thing is, you said regarding post-extubation oxygenation. That is for every patient. And more so, let me tell you, when the patient is already in an intensive care unit and on a ventilator, where you're giving a trial to this patient on a T-piece trial or a spontaneous breathing trial, SBT trial, where you are trying to see that what is the pressure the patient is having at the time of extubation, always keep in mind that this patient will need the same pressure after extubation. So if you bring the patient to a minimum level of CPAP of 6 centimeter water, that 6 centimeter water has to be given in the post-op period, post-extubation period as well, right? So this is again a different thing. The other thing you said is, what was the other point you said?
T-piece trial.
T-piece
Yes,
trial.
sir.
Now, T-piece trial, actually, T-piece trial has become obsolete, because all the ventilators, they have the spontaneous breathing system. That means the CPAP minimum level pressure, because that's the pressure which is needed for the patient to maintain his oxygenation. That is minimum pressure. Even on a ventilator, you have to put the patient minimum 6 centimeter water to 8 centimeter water to patient on PSV, pressure support ventilation, so that the patient can generate the tidal volume, which is pressure which is needed for the circuit pressure and the endotracheal tube pressure. So that pressure TPIS trial is, CPAP trial is a very common nowadays. We talk about the RSVI, rapid sequence breathing index, and we talk
Minimum
about
pressure
the minimum pressure support which is needed. So they are all there. But
Yes.
what I want to emphasize here is, I think we should not mix up with the extubation in an intensive care unit and extubation in a regular operation theater. So they are two different things. Yeah, that's the thing.
We have a couple of
Yeah.
questions with us.
Yeah.
Dr. Mohit, does extubation failure due to cardiac failure also a part of these guidelines? Extubation guidelines by identified.
Extubation failure due to cardiac failure.
Sometimes
means-
patient have say cardiac failure, pulmonary edema, and we
Ah.
want to re-extubate, and we talk about negative pressure pulmonary edema. So do you think these are also included in the extubation guidelines?
See, again, as I said, so whenever we talk about cardiac failure, so we got to first think on optimizing the patient's cardiac status. The patient has a pulmonary edema, you got to clear that pulmonary edema first. So you have to treat pulmonary edema. Once the pulmonary edema is being treated, and we know the patient has now recovered from pulmonary edema, then the extubation is same as in any other situations. There's no difference in other situations. We don't need to keep the patient on, CPAP trial or put the patient on deep extubation. That does not hold good. Once the patient's lung is clear, because let me tell you one very important thing. If this patient who's having pulmonary edema must have been not critically ill before that. He must have been a healthy patient landing up to a pulmonary edema because of some other reasons. If the patient was already in critically ill and landed up to a pulmonary edema, then obviously the lung ventilation goes prolonged, and there in case you might not be able to extubate that patient. You have to go for tracheostomy, long run cases, infection comes in. So we should not mix again a patient with cardiac problem landing up to tracheostomy, and extubation.
To a certain extent, we are also mentioning in limb A, where we want to obtain the hemodynamic response. So to a certain extent, it will also include in a cardiac patient where we don't want those hemodynamic fluctuation, and to patient go peri-extubation into cardiac compromise. I think that strategy to a certain extent is a part of our limb A also.
But no, then let me tell you, that patient is not landed up to a pulmonary edema. You're talking in a situation where the patient has landed up to a pulmonary edema. So your limb says that the patient should not land up to any hemodynamic uncompromised.
So here he talks about cardiac failure also. So in that sense, we can say that hemodynamic compromise should not happen.
No, we will not take a patient in this situation. We will not see, this is cardiovascular response. When we're talking about cardiovascular response, we are talking about the patient in neurovascular response, neurocerebral response also. These patients are patients where we think that the patient can be hemodynamically unstable at the time of extubation, where you have to take precautions. If the patient is compromised, then obviously that means the patient is not decompensated. It's compromised or compensated status. There you have to take this precaution. But if the patient is already decompensated, then obviously got to put the patient on tube and put the patient on ventilator and optimize the situation for that. So there is different.
Okay. So
Okay.
Dr. Mohit,
Yeah.
Dr. Mohit, what is your say about using lignocaine gel on the endotracheal cuff for preventing the response or the cuff at the time of extubation?
Means you're talking at the time of extubation, patient has been intubated. When you're intubating the patient with lignocaine gel.
Yes.
That's not. Yeah.
Yes.
So yes, that's it. There are a lot of studies. There used to be a lot of studies. What we have suggested, you can put an lignocaine, preservative-free lignocaine in the endotracheal tube cuff. So that is a better option than putting a gel, because putting a gel at the cuff can cause a lot of irritations and sore throat as well. But in putting a lignocaine, liquid, what I mean is lignocaine, lignocaine fluid inside the injection of, in fact, preservative-free inside the cuff is a better option. So that can avoid.
How much volume do you usually instill into the cuff, lignocaine?
It is around 3 to 4
ml. Routinely the recommendations, there are, when we have gone through the literature search, The various volumes were suggested, but the most common volume which was used was 9 ml of lignocaine plus make it alkaline with the help of 1 ml of soda bicarb addition. Okay. So when you make it alkaline, it helps because 4 ml sometimes, so you can gradually instill it. Whatever makes your leak go away, that is the volume you should instill. Okay. But for adult patients, mostly 8 to 10 ml of drug would be required to take, to keep your leak go away, like going away, and with the you will have a proper ventilation. Adding a soda bicarb, there were some studies where soda bicarb was not added. In some studies, soda bicarb was also added. In fact, there are meta-analysis which suggests that it definitely reduces the what you call laryngeal sequelae, laryngopharyngeal sequelae. That means cough and sore throat is definitely reduced. There is a good amount of evidence. For hemodynamic sequelae, the evidence was slightly weaker. But since it is a practice which the studies which were published were from some countries where we were not sure about the meta-analysis level, so we have downgraded it to level B. But there is a very good evidence which suggests that using lignocaine intra-cuff will definitely help you.
Yeah, but then the similar volume
Rakesh,
is, volume is a variation actually there, depending upon the cuff size. Depending upon the cuff size, it varies. That's a variation in the size. So you can start
so you gradually
5 ml.
instill, and wherever the leak goes away, you
start
stop.
with 5 ml and you can go until the leak is there. Yeah.
Dr. Diraj, your experience regarding
Dr.
this? Dr. Srinidhiraj, sir.
So my experience regarding
use of lignocaine distillation, lignocaine gel.
Cuff.
No, I have that limited experience on lignocaine gel installation. So mostly we are not like installing the lignocaine. One thing we can do is that IV lignocaine we can give before extubation. But installing the lignocaine in a cuff, I have very limited experience of that.
But that's right, that the lignocaine can also be used intravenously at intubation as
Yeah,
well as
that we have. Yeah.
Dr. Saurabh Sarkar.
Okay, doctor. Yes.
Sir, good evening. Thank you so much for giving me the opportunity to talk. Sir, actually, this is like my life coming to a full circle. Dr. Parthasarthi was the one who suggested me my thesis topic, which was actually putting intracuff lignocaine in the ET tube, and we were checking the results of post-op cough and sore throat. So I see Dr. Syed and Dr. Parthasarthi here at the same panel today. So, and this question, like the volume of the drug that goes intracuff, so it ranged from around 12 to 17 ml on each 7 mm cuff or 7.5 or 8. What I tried to keep a baseline was the cuff pressure manometer. The volume used to vary according to the anatomy also at times, because when we are filling air, the one-way valve, the pilot balloon keeps the air towards the cuff. But when we are filling up a fluid, be it normal saline or be it lignocaine, the fluid tends to come back into the pilot balloon because of the pressure of the trachea. So the volume was never constant. I used to try to measure the cuff pressure with the cuff pressure manometer to keep the pressure around 20 to 25 mm of water. And that was it. Like there was no fixed volume that I could insufflate it with.
I think this is an important point that especially when you're doing surgeries, patient is on ventilator, airway pressures are fluctuating. The cuff pressure will not remain static and it will change. That is what is actually happening because, for example, patients with lung pathologies or laparoscopic surgeries, when the intra-abdominal pressures rises, the cuff pressure, because everything is shifting up, it may also rise, and that's why the region is variability. And that's why the guidelines and the other literature also says continuous monitoring intermittently. Though many people are not using nitrous oxide now, but earlier the nitrous oxide usage was also associated with some amount of increase in cuff pressure over time. So I think this is good, and thank you for sharing your research. Wonderful research coming from India. We have another question from Muthukumar Rajgopalan. How much sensitive is the leak test for occurrence of stridor? We do agree that the leak test is not highly sensitive. It is somewhere around, if I remember correctly, around 0.5, 0.45 to 0.55. But it is quite good tests as a screening. So when you are doing this extubation in these type of patient, look all the overall context. For example, a patient who has undergone in the neck, the nodal dissection, or there has been multiple handling, or the surgery has been done in the head and neck area, possibility edema will be much more, and you should also look for other aspects rather than solely on the leak test. And that's why the AIDAA guidelines recommend leak test. And Dr. Reshu also mentioned, Dr. Mohit mentioned, leak volume of less than 110 ml or 10 to 15% of tidal volume. This is quite good to pick up whether actually there is edema or not while the extubation is planned for these patients.
At least you get some idea about it. That's
We have Dr. Ellen Sullivan. She is the past president and the founder member of Difficult Airway Society. You all must have heard and read the Difficult Airway Society guidelines. She was busy in the operating room. So Professor Sullivan, if you are free from the OT, can you join back?
She has put the message that she's going back. She's leaving, so I'm not sure whether she's there or not. But we can proudly say that she has accepted our invitation and she's coming to NSE 2026, and we all look forward to hearing from her. Because I think she has put a message that she has to leave. She's in OR and she's in Ireland, so basically they have a different time zone. So she's working right now, so she's not there, but she has put her message here. And we will look forward to hearing her in person in National Airway Conference in Delhi.
I think
so shall we move? It is already 8:26. So shall we move to the
quiz?
Yeah, so we'll move
our Kahoot quiz section.
So while
Yes, sir, please go ahead and then I'll start. Yeah.
So while Dr. Amit is settling the Kahoot quiz, as usually after the seminar, the webinar, we usually carry on the quiz on the Kahoot model. So before we proceed, my sincere thanks to Professor Syed Mohid Ahmed for a very interesting and lucid talk in the extubation, summarizing very comprehensively the AIDAA 2025 guidelines. And also, I want to have a sincere thanks for Professor Sanjay Dhiras, Dr. Kanta Bhati, Dr. S. Parthasarthi, Dr. Sujit Kumar, Dr. Reshu Gupta, all are big doyens in anesthesiology and doing a wonderful work in anesthesiology, pain medicine, as well as airway management. So special thanks to each of the chairperson to come, join from this very busy schedule and have given their opinion for the extubation. Thank you, each one of you.
Thank you, Rajesh. Rakesh, thank you, Dr. Amit. Thank you.
Thank you so much, sir. So thank you, madam. Thank you so much.
Thank you so much, sir.
Thank you so much, sir.
So please be with us as we move into a very interesting session. The winner gets direct entry into the quiz section of NSE 2026, and they all get certificate and a discount voucher for National Airway Conference. Okay. So that's a game pin for you. I hope that is visible. You need to go to Kahoot it, www.kahootit. When you go there, it will ask you for a game pin, and you straight away put this pin, which is 9330179. Probably you can also scan this if you have an option of scanning. Then you can scan this scanner code also, which will also take you to the Kahoot it app or the Kahoot it browser on your web browser. It will ask you for a pin. Please put this pin. If you have any issue with the joining, please put it in the chat box in the Zoom. There can be some unsolved queries because of lack of time, if that is happening, you can contact any one of us, Dr. Dr. Rakesh, or Dr. Mohit sir, or any of the chairperson. They can even discuss later on also. So pin is 9330179. If anyone has any issue, please let us know. So game pin is, if anyone is facing, please let us know. You can even unmute and speak if you are facing any issue. Okay. We'll wait for 2 more minutes as more people are joining. There are at least 50 participants in the
Sir, how
Zoom,
can we join?
and so you need to go to any browser, or you can, if you have any other mobile, you can scan this, or you can go to on your web browser www.kahoot.it. Okay. When you go there, it will straight away ask you for a game pin. Okay. And the game pin you must enter is 9330179.
Okay, sir.
I think there are 49 participants right now. If you are facing issue, do let us know. We can wait for 1 more minute. Rakesh sir, should we start at 8:35? Please try to put your name rather than, the name which is given by sometimes by the Kahoot itself. So we can identify and then send you the certificate, or the, we can identify the winner also. I think we'll wait for few more seconds and then start. You can also join later on if at all you're not able to join now, because later on also the game pin will be constantly displayed at the bottom of your screen. Are you all there? Dr. Rakesh, should we start?
Yes, sir, we can start, sir. I think we have,
Okay. 23,
so we have posted the pin
I think some of them
into
are
the group. Maybe another 1 minute or so. So we repeat the pin as 9330179. So all those who are willing, they can join. And just to reiterate, the top 3 reviewers, top 3 winners of today's quiz will get a certificate, and all will get also a participation certificate.
Okay. Okay, so welcome to AIDAA Extubation Readiness, AIDAA 2025 guideline for the at-risk airway. Okay. So this is again, all of you are welcome to National Airway Conference 2026, which is an collaboration with International Airway Management Society And we are also simultaneously hosting IAMM 2026 at AIMS New Delhi. The dates are 9th, 10th, and 11th October. You can scan or you can visit AIDAA.in, our website, for information and registration. Please join us at National Airway Conference in New Delhi. Before we start, we would also like to thank our quiz master for preparing these questions, Dr. Kiran Mahendru, Dr. Indubala Maurya, Dr. Shilpa Bhatt, and Dr. Shripad Mehendale. Please, thank you very much. A big thank you for making this possible. As you know, we are conducting this. This is 9th Quizinar we are conducting. There are somewhere there are some images are there. They could be misleading, so image may not be represent exact question or answer. So concentrate on questions and options, because it is the one who give correct answer first. Okay, not so correct and fast to gain more points. So you need to be quick and correct to gain more points. Okay, those who are correct all of them will get point, but those who is first will get more points than the next number. So let's get started. Okay. Question 1. The acronym SAFE in AIDAA 2026 guideline, and your options are Stratify, Risk, Airway, Facility, Emergency, Assess, Facilitate, Extubate, Assemble, Anticipate, Facilitate, Extubate, Evaluate, and Escalate. I'll not tell you, you can read. Okay, and your correct option is option C, that is Stratify, Risk, Assemble and Anticipate, Facilitate, Extubation, and Evaluate and Escalate. So evaluation and escalation is somewhere where was a difference in most of the options, and the correct one, which is given by I think more than half of them. Okay, let's see the winner. So the winner is named by NP with 874 points, followed by Vikram, and then Muthus and Rasika and Saurav. Let's go to the next question, which is not included in 3DS. Okay, not part of 3DS. So you really need to listen to Dr. Mohit sir's lecture, or you need to really read this. Okay. All 26 answers have come. And yes, half of them have definitely done it correctly. That's the delay was not there. There is a difficulty, there is a disease, there is a distortion. Delay is not there. Okay, let's see the leaderboard. And leaderboard, NP is still leading with 1777. Vikram is right there. Saurav has come up. And now there are two more, Vansika is the highest climber who has climbed by 6 numbers. But Hemant and Pavitra. Okay. Next, 3S in AIDAA extubation framework includes. So we got questions for 3D, now 3S. Let's see. The correct one is secretion, swelling, and stenosis. Others were little confusing. The correct one is, so again, half of them have given correct answer. And now Vikram has come up, followed by Saurav, Pavitra, Hemant, and Konark. Let's see the next. So what is parox? I feel everyone should give us a correct answer here. Wow. So most of them have done it right. Sometimes in the hurry, you might, push the wrong button. peri-extubation oxygenation. One of the most important concept, I would say, is peri-ox in AIDAA 2025 guideline. You know, it's a name which peri-extubation oxygen would be the most important point. You should continue oxygen, you increase the reserve, give 100% oxygen, continue oxygenation while you're removing tube, and after removing tube, make all the efforts to give oxygen till patient is completely out of your anesthetic bed. Okay. So Vikram is still leading with 3540 points, Saurav, followed by Saurav, Hemant, Konak, and NP. Okay. We are at question 6. What is stage sequential extubation? I hope everyone gives, most of them have given a correct answer. It is intentional extubation preserving airway access via AC and guide wire. Okay, let's see the. Vikram is still leading. He is always fast and first. Saurav, Konark, NP, and Muthus. First priority in unanticipated extubation failure is. I hope this also everyone gets it right. Yes, restoration of oxygen is something which is the most important point whenever there is a unanticipated extubation failure. That means you're not anticipated, you're not used airway exchange catheter, you're not done any of other things which is required. You're not put airway exchange catheter, which makes your re-intubation easy. The first priority in unanticipated extubation failure would be restoration of oxygen. Again, Vikram is leading, but very narrowly away from Saurav and Konark. So come on, Saurav, Konark, and others. You can still join the leaderboard. Airway ultrasound predict extubation strider. There's a lot of discussion on that. So the most of them has given correct answer. Airway column width less than 9 millimeters suggests that there are higher chances of developing, stridor because of the edema. So it does suspect the edema if your air column width is less than 9 millimeters. Okay. Now the leader is Saurav, but very narrowly followed by Vikram and Konar. And Pavitra is coming up back. She is. Okay. The next question. A positive quantitative cuff leak test suggests your post-extubation stridor is. Okay. And the correct answer is VT difference, and most of them has given right. And let's see the leaderboard. Still Saurav is leading, narrowed by Vikram and NP. The next, second last question. There are some errors which are innately done by someone. It's not the answers. Please look at your queries. And most of them has done it right. Again, should be avoided it should not be given. No oxygen insufflation through airway exchange catheter. You should use all other means other than airway exchange catheter. The company does provide a special adapter which you can connect with your breathing circuit. Also, you can connect with the jet ventilation. Try to avoid giving oxygen through airway exchange catheter. You can give nasal oxygen, you can use mask, you can use CPAP, any other modes, not through airway exchange catheter. Vikram has come back and he is leading with 7679 points, followed by Muthus and Saurav. So on to the last question. Which one is true? I think everyone should give this correct. We have 27 answers. All of 23 are given correct. Extubation is elective procedure requiring planning. So it's an elective procedure. Extubation failure are consequential. They are rare, but they are consequential. They are associated with high morbidity mortality. Deep extubation is not routinely recommended in difficult airways, and extubation is not always safer than intubation. Intubation is a situation where you have a controlled environment, while extubation is uncontrolled environment. You do not have personnel around you. The senior has left. Patient is struggling, hypoxic. It is much more difficult situation than intubation. So let's see the final result. Number 3, AIDAA 26. Please give us your name in the chat box. Max with 7739 with 8418. The leader is Vikram. Congratulations, Vikram. Please share your name in the chat box so that we can identify and send you the certificates. Rakesh sir, your concluding remark.
Thank you so much, sir. Again, I request all the 3 winners can send your full name, because we will be sending you the certificate via email. And I'm sure that you must have filled the online Google form, which has the email ID, so that we can send you the certificate. So thank you, each one of you, and special thanks to our quiz masters also, which has actively contributed in the success of this Quizinar, including the quiz. Dr. Shripad, Dr. Kiran, Dr. Indu, Dr. Shilpa, for actively contributing.
And yes, sir. Sorry.
Yeah. So for actively contributing to the quiz. So thank you so much, each one of you, and keep tuned in. We'll come with another interesting webinar 2 weeks later, wherein we will talk about the AIDAA guidelines with regards to the something very peculiar about the AIDAA. When we talk about call for help, which is code D, we also talk about not only the difficult airway cart, but we also need to understand the importance of difficult airway kit. And we also need to think of the alert form. So there are certain other aspects which are very, very peculiar to the AIDAA guidelines and important for the airway management in perioperative care, outside the operating room, that is in NORA situation. I'm sure you will really update yourself and keep tuned in. Also, we again once welcome for the National Airway Conference, along with the International Airway Management Meeting, one of the largest international airway congress in AIIMS, New Delhi in October 2026. Visit the website www.aida.in, and you have all the details as well as the registration. You can do at the early rate, and the registration fees is going to increase in coming time. Also, we welcome for the abstract submission, the awards with regards to the innovation, and we'll soon be coming up with the flyer for airway management workshop for the undergraduate students as well as the nursing professional. So you can send your colleagues, your juniors, your nursing staff who are working along you to get trained in the airway management. So thank you once again, and special thanks to Dr. Amit Shah also. Over to you, sir.
Thank you, sir. Again, one more point addition to what already Dr. Rakesh said. The abstract has a chance to be published in our index journal Airway. That's our target. Of course, subject to review process, but all abstract we are planning to publish if it goes through the review process in our Airway journal, which is now indexed. Thank you all, Dr. Saeed Mohit sir and chairpersons for joining us today, and all the participants, delegates for actively participating in this webinar and our Kahoot quiz. Thank you so much.
So before we close up,
good night.
Just will keep for another 2 minutes. Some of the participants has entered the email ID into the chat. So don't enter there. There is a Google link form, Google document form. Only those who have filled the form will be get the certificate. So don't write it here. I'll request we'll keep another for 2-3 minutes the website open. So click that Google form and fill the details so that we can send you the certificate as well as a discount coupon for registering for the Airway Congress. Thank you, everybody.
Thank you, sir. Thank you. This was really a wonderful experience. Thank you so much.
Thank you, sir. Thank you so much, sir.
Thank you, sir. Thank you, Rakesh sir. Thank you, Amit sir.
Thank you, ma'am, for sparing time and coming and joining and giving your input, madam.
Good night. Good night, sir. This was really wonderful. Kahoot quiz was really great.
Thank you, ma'am. Thank you so much, ma'am.
Thank you so much, sir. Have a nice day.